Assalamu alaikum, everybody. I'm really thankful to the organizers of Neo Colloquium for inviting me here today to talk on this topic, and also a big thank you because I got an opportunity to listen to such esteemed speakers, and I really enjoyed the previous talks. I particularly liked some of the comments, like the last one which Dr. Khalid Haq made, said PPIs are bad and stop them, and he just put a full stop. And that's so close to my heart, that the overuse of these things, probiotics so close to our hearts and GI. So they were really excellent talks on this topic. Mine is a little diverse, and I've been given the responsibility by the organizers to talk about approach to diarrhea in the newborn. Um, I see a lot of experts sitting here in their fields, and I see experts sitting in the front rows and the back, and I would like your input at the end and some questions. If this is a very comprehensive kind of a topic, and obviously I cannot cover each and everything, but what is important, I will try to cover. Uh, Diarrhea is a common disease and a common illness and a global killer. We are aware of it. WHO defines it as a passage of 3 or more stools, liquid stools per day. But I think for newborns or for infants, we have to also consider that it's the definition of diarrhea is more than 10 grams per kilo per day of stools. So, for instance, if you have a patient of pancreatic malabsorption, he won't have watery stools, but he will have large, bulky stools. So you have to go also by the grams per kilogram. So a differential diagnosis, if you have a newborn with loose stools and a diarrhea, it's the approach will depend and be dictated by what time did the diarrhea start? Like how old was the baby? What was the choice of the feed? So these things are so important to ask in the history. When a mother comes to you bringing a neonate or you're called from the NICU, these things are very important to straighten out right from the beginning. What was the feed? Is the baby preterm or term? And is the baby being seen in NICU, or is the baby being brought to your OPD or clinic from home? Is there any family history? And if you remember just a little pathophysiology, that literally more than 5 liters of fluid is present at the ligament of Treats, which is the upper GI, and by the time you hit the ileocecal valve, you are down, and the total input to the small intestine is almost 9 liters. Out of this 9 liters of fluid, very little is what you have really taken in. You're not drinking 9 liters. So a lot of it is the secretions of the GI itself. And a lot of the fluid is absorbed by the small bowel, so that by the time you hit the ileocecal valve, you're left with about barely 3 liters of fluid, 3 to 4 liters. But in the large bowel, again, you absorb fluid, and by the time the stools are made, in a 3-year-old, it would be around about 200 to 300 grams. So, so you can say that if you have disease of the small bowel, you will have massive fluid loss versus a disease of the large bowel. This is just to make a little note of the pathophysiology of which diseases are more likely to have devastating consequences on fluid and electrolytes and nutrient absorption, whether it's the small bowel which is affected or the large bowel which is affected. So just to wake you up. Now, this is a very common scenario, so you'll guess it probably. A 21-old days baby is brought to you with a history of loose stool since a week. Now, since past 2 days, the stool has blood in it. Baby is having colic and straining. Birth weight was 3 kilogram and present weight is 3.8. Baby is breast plus formula fed. The referring doctor gave a course of antibiotics for 3 days orally and then parenteral. No tests are available to you, which is a common scenario. What is the most likely diagnosis? And what treatment can you offer? Anybody can tell me? Now, do you think it's okay to give antibiotics to this child first orally and then parenterally? I should hear a big no. This was an okay baby and started having diarrhea. What is the point of antibiotics? But I tell you, 100% of them, before they reach the gastroenterologist, will have had more than one course of antibiotic. Everyone. And even a neonate is given entamizole in our country. And remember, entamizole is metronidazole and diloxanide. What the hell is diloxanide doing in a newborn? So, so what do you think this baby? So yes, you're right. The ones sitting, the smart young men and women sitting there who have seen this. So this is more likely to be cow's milk protein allergy. So remember, for cow's milk protein allergy, you might have an enteritis, you might have an colitis, and you might have a very bad enterocolitis. So if you have just a colitis, your baby is going to thrive, gain weight, but is going to strain and have either occult blood positive stools or frank blood seen. And if you have a small bowel involvement, you'll have a child who's not gaining weight, who might be vomiting, who will have some abdominal distension definitely, and might even have low albumin. So, and then if you have enterocolitis, that baby seems like a sepsis one. Many times I'm referred a newborn for having significant vomiting and having altered blood in the vomit, bad loose stools, blood in the stools, raised CRP, thrombocytosis. They will always have thrombocytosis, leukocytosis, raised CRP. That is not an indication always of sepsis. So an enterocolitis-like picture can also be there. Now, the treatment of cow's milk in this particular patient, in the newborn, is not a soya milk formula, which is contraindicated. So a lot of times, so I'm just putting in some practical things so that my colleagues here can take home some message. Soya is contraindicated in this scenario. So what we need is either an extensively hydrolyzed or an amino acid based. And I know extensively hydrolyzed is not available in Pakistan because of some weird reasons. But amino acid based formulas are. So unfortunately, either you use breast milk, or then if you are a loser and haven't used breast milk, then you have to go to these expensive amino acid formulas. Now, what the timing of onset of diarrhea? Now, diarrhea that begins within a few days of birth, if it's within the first week of birth, is not likely to be fruit protein induced. It's not likely to be cow's milk protein induced, because you have a honeymoon phase in these kids. Just like for the, we say reflux vomiting starts immediately and pyloric stenosis takes time. Just like that, your milk allergy is a sensitivity. And that Khalid Haq Saab was saying that NAC takes time. If it's more preterm you are, takes time because it's an immunological response. It's the same thing with milk allergy in a neonate. It will take time. So if you have a patient who's 7 to 8 days old and has been having loose stools since he passed meconium, that's not milk allergy. So exceptions would be for the even for the later presentations, like if we say most early presentations we say are congenital causes, except for immunological disorders, which also take a little time to come. So if you have severe combined immune deficiency, you have immunodeficiencies of other sorts, they also will show you a honeymoon phase, because the mother's immune system has been looking after the baby, and the baby's immune system will take time to show you its deficiency. And the choice of feed. So if you have a breastfed versus artificial milk, if an exclusively breastfed baby develops significant loose stools, it requires a good workup and a referral. Not stopping breast milk so do not stop breast milk, please, ever, to change to a lactose-free formula. And I see that quite often, and that is why I say it here. Please do not stop it. Rarely it's only that we sometimes may stop the mother's dairy. So if you have, so is the baby preterm? So we're trying to look at the history and the way you're called in for diarrhea. Diarrhea with abdominal distension in a preterm in NICU, it might be due to necrotizing enterocolitis, and stool might be having blood in them. Neck might be responsible for short gut, which later becomes a cause of torrential diarrhea. Preterms, again, like I don't even need to go into it because Khalid Haksab made that easier for us, is they're more likely to show signs if they are an artificial feed. Remember, the preterms enzymes are not well developed. So if you give them the normal lactose containing, they might not have the lactase enzyme. And when you try to give them alternate formula, remember that all alternate formulas which are lactose free contain glucose polymers as a source of carbohydrate. And glucose polymers require glucoamylase enzyme, which also may not be fully developed in the preterm. So you end up with diarrhea on both fronts. Some babies in NICU will develop infectious diarrhea. Now, babies at home are far less likely to have infections as a cause in the neonate, but in the neonatal age, in the NICU particularly, you might have rotavirus, salmonella, shigella, E. coli, and the same can happen at home, but far, far less than after the first month. You see way more infections. Now, let's talk about this baby. These are all real life cases I'm showing to you, and I'll show you that. Now, this was an 8 days old term infant admitted to NICU for vomiting and abdominal distension and loose stools. Vomiting was sometimes bile stained. He was exclusively formula fed. Treated as sepsis on basis of raised CRP, poor feeding, abdominal distension, frequent watery stools, which for the past 2 days had blood in them. An examination tells you that it's a baby with abdominal distension and bowel sounds are positive. Don't you see that a lot in your nursery sometimes? Just like your previous speaker was talking about the diverse amount of distension with goic positive stools that you might see with diarrhea. Where is the problem here? The suspicion. Okay, let's see the ultrasound, the Doppler ultrasound. What does that show? Somebody can tell me? That is your whirlpool sign. What's a whirlpool sign? It's a radiological sign where when you have a malrotation, the mesentery wraps itself around the vessel and you see this whirlpool sign, which is pathognomic of a malrotation. So if you have a malrotation, and we can see this, and when you do, and please don't give them barium, give them your other contrast, and you can see in these cases that your small bowel lies on the right side. But a very important thing, if you don't see the rest of the bowel, if you see the duodenum, look at the DJ junction. In a normal person, that is higher than your bulb, and in these cases, it will be lower, and it will be sagging below the duodenal bulb because it's on the wrong side. So remember, everything which has diarrhea may not be just a medical reason, and you might have a surgical reason. Now, so I'll take you to the few causes which we see, and this is a patient from our NICU who was a 23 days old baby, breastfed, seen previously by ER doctors for complaints of abdominal distension. He was gaining weight. It's breastfed, mother says, processed frequent small stools, now brought with torrential watery diarrhea since 2 days, which has blood in it. And the X-ray is this one. So what is the diagnosis here, most likely? Huh? Absolutely. Herpesvrungs, and he has developed enterocolitis. And we do see these patients. So I wanted to take you over some scenarios which you will commonly see. But again, you have to interpret them in the context of every child. So the diagnosis and approach to any diarrheal patient in the neonate depends so much on your history and examination as well. And so we will tell you the diagnosis of this one a little later, because we're going to challenge your mind a little. 3 months old who has watery diarrhea and severe dehydration, stool reducing positive. You stop the feed baby and make them baby NPO, the stools stop. Now, so a very important group in the neonate is when you don't have these acquired causes, but you have a congenital cause. So you must always consider congenital causes of diarrhea in a newborn, especially which come on earlier, when before 10 to 15 days you have diarrhea. Before 2008, we didn't really have a lot of clue to these diagnoses because we didn't have access to molecular diagnosis. And then there was this blast of next generation sequencing, and all the patients that we did have, in retrospect, we can look at them and say, I think that's what they had. So, some pointers. Again, I would say a good history regarding the age. It's only and only for the immunological ones where you might have 3 to 6 weeks gap where an immune deficiency one will present a little later. Breastfed infant having severe diarrhea, malnutrition, or edema is a congenital cause until proved otherwise. History of polyhydramnios absolutely points to a congenital cause. Death of siblings. And first of all, common diagnoses like milk protein allergy, but then again, timeline is important. First 7 days of diarrhea, not milk allergy. Overuse of antibiotics you must avoid because it's never something that we need in diarrheal patients in a newborn. So we are tuned to thinking of antibiotics because of all the infections and horrible things that we see, but then we also, it's a problem producer, not a problem fixer. And this little baby died out of pseudomembranous enterocolitis. Somebody stopped feeding him, so even trophic feeds were not given. Baby had C. diff positive stools, very bad diarrhea with blood, and pseudomonas from the blood culture. And again, I have to say, never stop a child's breast milk. So if you have a baby with diarrhea, which is early diarrhea, you must examine the baby for any features. Is the baby looking any different, any syndromic baby? Does the baby have enlarged liver? Do you see any skin manifestations, any minor eczema, blistering? If you see disproportionate abdominal distension. So just for the neonatologist here, you classify the congenital diarrheal disorders with, you can leave the last bit, which is recently defined, and look at the first four. And when you look at the first four, remember to look at the picture, just for the youngsters to memorize. So you have disorders where you will have the transport problem, transporting nutrients across the small bowel. You will have disorders where when you come to the mucosa, you don't have enzymes to digest certain parts of the feed from your milk. Then you have disorders where you cannot form these epithelial cells properly. And then you have disorders where you have immunity, which causes problems and enteropathy. So we'll show you a case of each and every one. Now coming to the algorithm which you should always use. I made this algorithm myself just to make you understand a bit of it. Now, so if you have a baby who has no evidence of enlarged liver, hepato or major skin manifestations, go ahead, do your stool complete, do your stool pH, reducing sugars, see how the baby's stools are when you don't give the feed, do the serum albumin always. A low albumin indicates enteropathy. Look at serum cholesterol and triglycerides, and we'll come to it that which disorders you need to rule out. Always ask for stool electrolytes. So let's go to the first one. You have, when we come to disorders of transport, these are the disorders where your small bowel biopsies are always normal. So there's no point in referring them for a biopsy, but you have low stool pH, reducing sugars positives, and the diarrhea ceases on NPO. So you're dealing, so the most common among these is glucose galactose malabsorption. Now remember, you always are looking for, in Pakistan I've seen a lot of lactose-free formulas. Remember, congenital lactase deficiency doesn't happen in our population. And worldwide it is rare and seen in the Finnish population. So if you have osmotic diarrhea, severe ones, let's say even in a breastfed, in the first 8 days, think of this diagnosis. And we'll come back to these slides again for you. So a 6 months old, 6 days, I'm sorry about it. It should have been 6 days old. Brought with a history of diarrhea, watery stool since first week of life. He gets into severe dehydration, becomes acidotic, the sodium becomes really high, bicarb goes low, and these kids are mainly referred to us as suspected also inborn errors because they're so acidotic. But then they're also dehydrated and having diarrhea. The problem over here is that these kids have glucose galactose malabsorption. And because there's this malabsorbed glucose and galactose draws a lot of water, you have the hyperosmolar serum and the sodium goes high, and you have all these carb in the colon converted to short chain fatty acids, and your entire body pH is affected because of this acidosis. Small bowel biopsy, always normal. This is the kid, one of our kids, they become so dehydrated that they can have renal stones, and he passed renal stones as he grew to be 2 years old, because in the NICU he was so dehydrated and had hyperosmolar serum. Now, the next disorder, which is a prototype of epithelial transport defect, is your congenital chloride diarrhea. Now, this causes watery diarrhea with dehydration right from, even their meconium is watery. Stool chloride is always high. Now, they have hyponatremia and alkalosis. Their stool looks like urine. Sometimes you get mistaken that the baby passed and has history of, you might have picked up dilated bowel loops or polyhydramnios. The treatment is symptomatic. This is one of our babies with congenital chloride diarrhea. And you give aggressive replacement. They make their feeds even in ORS. You give, in this particular patient, you cut off their acid by giving them PPI. You give oral butyrate. They thrive and do well, but their diarrhea persists. But you actually correct the metabolic abnormalities and they thrive. Now, coming to this baby, a 15 days old, admitted in nursery since 5th day of life. Diarrhea since 1st day of life. History of polyhydramnios in mother. Watery meconium passed only for 2 days, followed by intractable watery diarrhea with persistent metabolic acidosis. Again, this particular kid, you cannot forget this level of abdominal distension, which you mainly see in surgical causes. So if it's not a surgical cause and this much level of abdominal distension is there, think of congenital sodium diarrhea. That is also a transport defect. But they will have significant acidosis. So they will have intractable diarrhea, and this diarrhea happens in the intrauterine life as well. That is why even your meconium is watery. And it's you might have a bit of a syndromic form sometimes, but mainly in Pakistan, we have seen the non-syndromic form. Now, there is marked abdominal distension, and these kids obviously cannot do without TPN. So to differentiate between the two, between the congenital chloride diarrhea, in the that the chloride in the stool is more than sodium and potassium combined, and in congenital sodium, the sodium is more than the chloride and potassium combined. Now then we come to the epithelium. If you think of the epithelium, it has enzymes in it. So deficiency of sucrase isomaltase never really comes in your neonatal period unless and until mother is adding sugar or you are using a formula which is lactose free. So this small bowel biopsy would be normal, but the child would have osmotic diarrhea. We only have one patient in our series. It's a very rare disorder, but this is not an uncommon one. This particular one is the deficiency of the DGAT enzyme. This has got a devastating protein-losing enteropathy, growth failure. As soon as you start taking normal formula, which has fats in it, the baby starts to have a lot of diarrhea, which is like a steatorrhea. And this is similar to another enzyme defect. So this is the deficiency of DGAT, and you have this gene very common in Pakistan. Then you have A-beta lipoproteinemia, a similar presentation, intake of lipids, and you start having diarrhea, which is like a steatorrhea. And that is why it was important when you go back and I asked you to do cholesterol and triglycerides. In these conditions, they will be really low, far lower than the normal expected in the newborn. So the treatment is you restrict the long-chain triglycerides, you give them MCT supplemented milk, and they thrive and do well. This is a peripheral smear of one of the children. As they grow older, they will have, what do they have in the retina? They have retinitis pigmentosa. And this is one of our children diagnosed as a small baby, doing very well, as she's an A-beta lipoproteinemia on her genetics, but doing very well on diet. Then you come again to one of the another enzymatic defects, which is the gene is there in your country, and this is a devastating one. Remember your enterokinase enzyme, which is responsible for triggering and activating all the pancreatic enzymes. So this is the first step. But if the first step is missing, you have a devastating diarrhea, malabsorption, fat, as well as other nutrients, and that's the baby which has enterokinase deficiency. All edematous, they're not digesting their protein. They have total lack of fat absorption and protein as well. So carbs is the only thing they're probably going to digest a little. So you have the epithelial transport defects, you have the enzymes, so you can see all these. And this is inside the epithelium, the enzymes, and these are the transport defects that we spoke about. So it'll make it easy if you think like that. And when you come to the defects where your villi are not being developed properly, it's not a matter of enzymes, it's a matter of developing the villi. This is Muhammad. This whole family from Gujarat suffered this condition. And we have this gene quite a bit. The microvillus inclusion disease gene, profuse watery diarrhea. They have low albumin, they don't have appropriate villi for absorption. When you do the small bowel biopsy, you see no villi there or very few villi. And in fact, you have the crypts also are hyperplastic maybe over there, but there is no villi for absorption. They cannot survive without TPN or small bowel transplant. This kid survived for 2.5 years on TPN and finally referred for small bowel transplant but died before that. Now, again, this is a diverse disease, the microvillus inclusion disease. This patient was referred from Islamabad, was being treated as a glucose-galactose malabsorption for some strange reason, was on galactomin 19. Remember, your glucose-galactose malabsorption dramatically becomes okay the moment you give them fructose-based formula. And if they're not doing well, don't give them this 10,000 ka formula and think about the diagnosis. So this baby was considered that and had multiple albumin transfusions, blood transfusions. Father, I think, works in the military. And this is the baby's biopsy. And this is the baby's genetic result. This is very similar to microvillus inclusion disease. It's a tufting enteropathy, where you have basically there's invagination of the microvilli they do not develop properly, and your microvilli get invaginated into the villi, and you have this kind of a picture. And so you see the tufts. It does occur even in the absence of feeding because there is a bit of secretory diarrhea to it. So remember, microvillus inclusion disease and tufting enteropathy behave in the same way, but there's a whole diversity to the phenotype in your country. You might have a newborn who can't make it without TPN. You might have an 8-month-old who's severe failure to thrive, but is surviving till 8 months and might be able to manage on high-cal feeds along with TPN without a small bowel transplant. So then we come again, I'll go back to this one. Remember what I said to you? So if you have low albumin, loose stools, persisting despite, then you must do a small bowel biopsy and think of these things. High fecal sodium, consider congenital sodium diarrhea. High fecal chloride, congenital chloride diarrhea. Low triglycerides, low cholesterol, think of beta lipoproteinemia, hypolipoproteinemia, and chylomicron retention disease, which is the Anderson disease, which is the DGAT enzyme. I won't dwell for long on these, but rarely do you see them before the end of 4 weeks. If it's a very bad immune deficiency, you might see a newborn with severe diarrhea. The characteristics of these are frequently there is blood in your stools. And there is a resistant diaper dermatitis. Mother says, मैं इतनी nystatin use करती हूँ, मैं इतनी antifungal लगाती हूँ, ointments लगाती हूँ. This thing is not going away. Frequently, you will see some skin changes in those children. There might be eczema, there might be blistering lesions. Sometimes the blistering lesions are something that our dermatology colleagues are referred to when they call it epidermolysis bullosa. I recently had an immune deficient child of 29 days old diagnosed as epidermolysis bullosa because he was having blistering skin lesions. Remember, but had diarrhea, which had blood in it. So remember, if you have this combo, think of immune deficiency. So these are some of your early onset severe diseases, and you see that you may have perianal fistulations in these patients. And remember, perianal fistula in a young child, in a little baby, is always immune deficiency. When you go beyond 6 months to a year, then we say either immune deficiency, Crohn's, or tuberculosis. But if you see it in under 3 months, it's immune deficiency, immune deficiency, immune deficiency. There's nothing else. So this is another condition which is pretty common. And we said, remember syndromic features? So if you have hair which is falling out and you have particular yellow set ears, syndromic features, this is a secretory diarrheal gene which is common here. And you might have intractable diarrhea starting from the newborn. We call it the trichohepatoenteric. So there is hair which is abnormal, the liver is enlarged, and watery diarrhea. Many of these patients, because of enlarged liver or spleen, are referred as lysosomal storage disorders to us. But these patients have some degree of facial dysmorphism, and this is a common gene in Pakistan. Now, some of other things which are not that common. Remember your Fanconi Bickel, which is one of the types of GST. You will have hepatomegaly, watery diarrhea. Urine has glucose in it, and you might have tubular nephropathies along with diarrhea. Think of Fanconi. Very rarely would you have the genetic acrodermatitis enteropathica coming in the first month. Even that would be like end of first month or after the neonatal period, with rash and the typical zinc rash, deficiency rash that you see. So this is just our data in the last 2 slides that I got for you. Dr. Anjum helped me in compiling this data, and my team, I'm really thankful to them. We looked at the various congenital diarrheas and enteropathies. So our gene identification rate, as you can see, is really, really high. That almost half of the patients in the neonatal age who were referred to us had a reason, a congenital reason for having diarrhea. And you can see all those that we spoke about. But a huge chunk is either the electrolyte transport defect or the epithelial. You can look at whether this is the epithelial enzyme defect or this large chunk of patients with the microvillus inclusion. The immune deficiency are there, but I would say think of these 3, always rule them out. Immune deficiency will come to your mind by the time the baby comes to you with these kind of things, but these are likely to be missed, the 3 things on that side. Okay, I think so. Lastly, I would again reiterate that the approach to a newborn with diarrhea requires a very comprehensive understanding of the causes. So causes of newborn diarrhea are very different from causes in an older infant and child. Infection will constitute a far smaller percentage. The timing of onset, the type of feed, it matters so much. So you cannot diagnose without taking a good history. The surgical causes can have diarrhea very frequently, so you must rule them out, particularly if you see abdominal distension. Milk protein allergy is a common cause, and the selection of the formula is important, so as not given in a newborn. Congenital diarrhea due to these monogenic disorders is an extremely important consideration in early onset diarrhea, and you must refer for molecular testing. An algorithmic approach is needed, and breast milk should not be stopped. You should refer such a patient before you even think of stopping breast milk. And thank you very much.